So now I am very happy to hand the word over to Dr. Christof Renner, who is the head of the neurosurgery department at the Community Hospital Dessau in Germany. He is the author of several articles published in international journals. He recently contributed to an article on salvage radiation therapy for patients with relapsing glioblastoma multiforme and the role of slow fractionation. Dr. Renner, may I hand over to you?
Yeah, thank you. Yeah, as you heard, my name is Christof Renner. I'm from neurosurgery from the Community Hospital in Dessau, and I will talk about the GLOW800 in neurovascular surgery and our first experiences with this technique. So welcome, ladies and gentlemen, to this session. I think it's common sense that the intraoperative neurovascular and fluorescence angiography is very, very helpful unless crucial for a safe and optimal neurovascular surgical intervention. And so far, I think probably most of you are familiar with the usual technique in fluorescence angiography, meaning that after installation of the ICG, you see the angiographic picture on a separate black and white screen in a two-dimensional manner. And then you have to switch your view from the microscope to this screen, and then you have to in your imagination, you have to overlay the picture of the microscopic view with the picture of the screen. And sometimes you have to switch about these two modes, and this might be sometimes inconvenient unless, or it might be problematic. So the GLOW800 technique is a technique which goes one step further. And you don't have to turn away from the microscope. You can stay on the microscope and you see through the microscope the angiographic picture in a normal microscopic view, three-dimensional view, and in a white light modus. And you have an optimal depth perception. So at the beginning, I want to summarize some requirements for the GLOW800, which we should demand from this technique, that we can say it's a very helpful and a very advantageous technique for neurovascular surgery. And after that, I will show you some clinical cases. So I think it's necessary that this technique provides us the real-time information about the blood circulation, the blood perfusion, during the arterial and venous phase, not only in the underlying lesion itself, but also in the adjacent or surrounding vessels. And with this information, you should be able to select the safest way or the best strategy in the treatment of the surgical, in the therapy of the surgical therapy for that lesion. And furthermore, you are able or should be able to verify an effective and definite elimination of this lesion. Simultaneously, you can exclude or should exclude the pathological perfusion in the adjacent vessels. And of course, with the GLOW800, you should be able to do this without a turn away from the microscope, so that you are able to perform a controlled, straight, and tight workflow. So we come to the first case I want you to present. And this was a 55-year-old male, and he had a secondary diagnosis of chronic alcohol abuse. But acute, he came to the hospital with a TIA and a left-sided, temporary left-sided hemiparesis. And after the adequate diagnostic, patient got a CT angiography and an MR angiography. And as you can see, The right internal carotid artery is not contrasted up to the intracranial levels, like here. And corresponding to this, you see here in the diffusion-weighted imaging, some freshly infarction areas in the right internal capsule or the right basal ganglia. And so we could state the diagnosis of a spontaneous thrombosis or dissection of the right internal carotid artery up to the C6, C7 level intracranial. But what this patient also had was 3 incidental aneurysms we found during the diagnostic angiography, cerebral angiography. And he had a left side, on the right side, on the left side, an MCA aneurysm complex and a little bit bigger, and an RCA aneurysm and a smaller ICA aneurysm on the right side here, right over the thrombosed area. And after recovery of the neurologic deficits from this, of this patient, we decided about 8 months later, after anti-coagulation therapy, we decided to treat these 3 aneurysms. This aneurysm was clipped operatively. This aneurysm was treated by endovascular coiling, and the smaller one, ICA aneurysm, was again clipped. And this is a case I want to show you. And we decided to do this under GLOW800. And as you can see here, we performed a small carinal approach. As you see here, the optic nerve. You see here the A1. This is the thrombotic area of the ICA, the C6, C7 area. This is the aneurysm, partly covered by plaques, but on the median side, a very thin wall. And this is the median media. And so you see the GLOW800 and the coloring, the green coloring of the aneurysm, and the right anterograde coloring of the media. And you see also a retrograde coloring of the RCP here and the anterior choroidal artery. And you see we expose a little bit more. You see here the anterior choroidal arteries, the RCP. We can all the needed structures see and expose. And now we can maybe a little bit hurry. Through the video. And after clipping, we repeat the GLOW800 to make sure that the aneurysm is excluded from the circulation. And now you see the right filling and the correct filling of the vessel structures. Here the A1, here the media, here the retrograde filling of the carotid artery to the RCP and the anterior choroidal artery. And what you see now is that we play a little bit with the working distance and the zoom, and you say that the overlay between the fluorescence signal and the vessel is not optimal if you do this, but now it's again optimal, and you see that the aneurysm is totally excluded from the circulation and the underlying vessel is okay. There's no narrowings because of any kind of plaques or so on. So, oh, pardon. Okay, so we come to the second case. It's also an aneurysm case. This was a 57-year-old female. And this patient had 1 year ago a severe SIH with a stadium 4, according to Hunt and Hess. And this was caused by a ruptured MCA aneurysm on the right side. This aneurysm was operated in the acute phase, as you can see here. But what this patient also had were 2 more aneurysms on the left side, which we found in the diagnostic angiography at that time. And you see here 2 small aneurysms, 1 small aneurysm at the anterior choroidal artery on the left side and a smaller aneurysm of the ACA or RCA on the left side. And what you can see also is here a kind of fenestration of the RCA here, and you see it better in the reconstruction here. We have 2 branches of the RCA, and this branch goes rightly out from the basis of this aneurysm, and you see on the side view a little bit better the anterior choroidal artery aneurysm and the RCA. And this patient recovered from his bleeding, from her bleeding, and she recovered in an acceptable way. She had a persisting high-grade hemiparesis on the left side that she was mobilized in the wheelchair, but she was able to take part on the daily life within her family. So we decided 1 year later to exclude these aneurysms from the circulation with surgical clipping, and to do this under GLOW800, which I want to show you now in the next video. So again, it's a pteronal approach. You see here the optic nerve. We begin to expose the structures by opening the fissure, the proximal fissure, sylvian fissure, and to open the carotid, optical carotid cisterns. And maybe we can go a little bit further, faster through the video. So now you see we began to expose the aneurysms. You see here the choroidal artery aneurysm is a small one, and now we prepare and expose RCA aneurysm on the left side. So you see here comes the lower branch of the RCA, which goes right out from the basis of this aneurysm. This is the A1, the A2, the aneurysm. You see the thin wall of the aneurysm. And now we make sure that everything is well prepared through the aneurysm. This is the A1. And here we expose a little bit the A1 on from the right side. Okay, so if we finish the exposure, then we turn to the glow modus, and you see the correct and rapid filling, arterial filling of the structures. And you see again, if we play with the working distance or if we play with the zoom, you have not an optimal overlay between the fluorescence signal and the vessel. So you should be aware that you always have the right working distance and the right zoom. So like now, again, you see an optimal overlay, and it's perfect. You have the optimal depth perception. So after the first glow, we performed the clipping. And again, we do the glow, and you see a correct filling of the vessel structures, the A1, A2, and the RCA branch, the lower RCA branch, no signal in the aneurysm. and no narrowing of the underlying vessel, and the A1 on the right side is also correct in the angiography. And now we go to the second aneurysm, the choroidal artery, anterior artery aneurysm here, partly covered by a plaque. This is the carotid artery, and here is the anterior choroidal artery, which goes out from here. We have to manipulate a little bit. So here you see the anterior choroidal artery, a correct filling. And now after clipping, we have to make sure that there is no narrowing of the choroidal artery artery. And you see, again, after the further glow period, there is a correct filling and correct inflow of the fluids, the ICG in the anterior choroidal artery. So we excluded completely the aneurysm from the circulation. We come to the third case. This was a 74-year-old male, and this patient came with a slightly progressive gait disturbance over the last year. And within the last 2 to 3 months, he needed more and more walking assistance. Also, he reported about recurrent diffuse paresthesias in both legs, but he had no vegetative disturbances. So when he came to the hospital, we found a mild to middle paraparesis combined with a diffuse dysesthesia in both legs, and he had a middle to high-grade spinal ataxia. And of course, this patient got a MRI scan of the spine, and as you can see here, the patient presented kind of congestion edema in the lower spinal cord, in the lower thoracal spinal cord, down to the conus. And what you also see here, that the patient presented impressive picture of dilated perimedullary veins, like corkscrew veins, in this area, and this was highly suspected of dural arterial venous fistula, spinal fistula, and after the spinal angiography, we found the fistula at the 10th thoracal level. On the right side, you see here the segment artery, and you see here, you can see here, the fistula goes into the perimedullary venous system, filling it down and up. So we could state the diagnosis of a spinal dural IV fistula in the 10th thoracic level from the right side, and we decided to operate this patient on the GLOW800. This is what you see now in this video, and we exposed this area via an interlaminar approach between the 10th and 11th thoracic vertebral. And what you see here, this is the fistula, the fistula vessel. It comes directly out from the dura here, and it goes into the dilated venous system here, right. And now you see the glow, and you see the early, I stop here, you see the early arterial filling via this fistula, and the early arterial filling, retrograde filling of the venous, dilated venous system, or the corkscrew-like venous system. And so you see that this high arterial inflow leads to a little bit congestion of the arterial blood. Now we clipped the fistle and the fistula. After that, we installated again the ICG for the glow modus, and I think the arterial phase began, or must begin suddenly. And so now you see here the arterial blood a little bit, and you see no arterial filling here in this venous system from retrograde through this fistula, but now in the venous phase you see an anterograde filling of the venous system and a slowly or a delayed slowly filling of these venous vessels here, dilated venous vessel here, which was at the beginning of the which filled first at the beginning through the fistula. And that means that the fistula is excluded, definitely excluded from the circulation, and we can confirm now a right anterograde filling of the venous system. So you see the slow outflow from the venous system, and so we confirmed a successful treatment by a post-operative MRI scan 12 days later after discharge of the patient. And as you can see here, we see a clear decline in the congestive edema and a clear decline of the dilated perimedullary venous system. This is a clip artifact, and if you compare it with the preoperative scan, it's I think it's very clearly, and also the patient showed recurrent symptomatic. So we come now to the fourth case. It was a 67-year-old male, and this patient came with reported about a first event of convulsion with a temporary right-sided hemispasm and an eye-line fixation on the right side combined with an aphasia. This symptomatic was spontaneously recurrent, and several days later this event was followed by a second one with a speech arrest and an incomplete aphasia again. And this symptomatic was again spontaneously recurrent, and but this was the reason why the patient came to the hospital. But when he came during the examination, he showed no pathological findings, but what we saw in the MRI scan of the cranium, a pathologic finding in the occipital and temporal lobe in form of, again, a dilated cortical venous system, corkscrew-like dilated venous system in the occipital and temporal lobe, combined with a kind of congestive edema again in the occipital lobe. And you see here again the massive dilated veins of the occipital lobe. And of course, this patient needed extensive cerebral angiographic diagnostic. And you can see here that we found via the external carotid artery here, this is the occipital branch. You see here in this view, or in the lateral view a little bit better, multiple feeders, arterial feeders, and an arterial shunting, about multiple feeders through the bone directly in the sinus, in the transverse and sigmoid sinus here. And interestingly, this is only a segmented or restricted area of the sinus. The proximal sinus here, the proximal transverse sinus here, and the distal sigmoid sinus here is obliterated. So we only have this limited area of the sinus where the shunt the arterial inflow goes through and directly through this fistula point into the cortical venous system, causing this venous dilation and congestion edema. And we found some more feeders for this fistula point, like here via the vertebral artery. You see here a pathologic branch directly going into the fistula, and here via the posterior meningeal artery, and a pathologic branch here directly also in the fistula. And even the internal carotid artery had a feeder send a feeder to this fistula here from the C3 or C4 level, right into the fistula. So you see here again the shunting of the arterial blood via this common fistula point in form of the sinus, the shunting into the cortical venous system here, and the venous congestion. So we could state the diagnosis of a complex cranial dural IV fistula, and we decided to treat this combined under GLOW800 control. Combined means we made a surgical exposure of this common fistula point here, this restricted or limited transverse and sigmoid sinus, via an extended retromuscular approach. This is infratentorial, this is supratentorial, the dura over the occipital lobe. And we decided to pack and to eliminate this fistula point via intraoperative coiling. So this is what I want to show you now. You see here the common fistula point. And at the beginning, we performed the GLOW now. And you see the rapid arterial inflow and the rapid inflow via this segment into the cortical venous system, which you see through the dura here. These are dilated cortical veins here. And you see that is a high inflow. And now we began to treat this fistula. We punctured via a needle, and we positioned the wire through the needle and removed the needle. And now we can a little bit hurry. So you see, we positioned the catheter now into the sinus, the fistula, and then we began to pack. And maybe you see here the first coils. We wanted to see whether the catheter maybe is seen through the angiography. At the beginning, we did again a GLOW800, but we see no contrast of the catheter in the sinus. But you see also again the rapid high inflow, arterial inflow in the fistula, and the shunting in the cortical veins again. And now we began to pack this sinus. You see here the coils. We can support the positioning of the coils with the dissector a little bit. And here we started, we continued the coiling here. So we packed about the first third of the distal third of this sinus, open sinus. And again, the GLOW800 for control, and you see still a high inflow, arterial inflow in the fistula and the cortical veins, but you see here the beginnings, thrombosis and packing, successful packing of the sinus, and you can verify this without X-ray control. With the usual technique. So, and we continue to pack the sinus here, and you see as more the sinus is packed and as more it is thrombosed, as more rigid is the structure here. So you see here the coils, and we are in the nearly the end of the packing. So here the catheter swept out because we had to remove a little bit the catheter back. And we repositioned the catheter and continued the last coiling. So before we removed the catheter, we had to fix it a little bit, and then we performed the control GLOW800, and this is a rest signal intensity from the GLOW procedures before, but you can see here that there is an arteriovenous freshly inflow from the newly installed ICG, and no more inflow here in the fistula sinus. So we removed the catheter, and you see here the last rest of the last coil wasn't in this sinus, so we had to remove and to pack it back by hand. Or we can rush a little bit through this video. So this is at the end of the refilling with the coil, and we made a suture over the puncture hole to make sure that no coil is sweeping out again. And that's it. So to confirm this successful procedure and to confirm the GLOW800 result, we performed a control cerebral angiography 2 days later after the operation. And as you can see here, this is the packed fistula, the packed sinus. And again, while the occipital branch, you have no more arterial inflow in the fistula, and again, while the internal carotid artery, there's no more pathologic branch and fistuling in into the sinus, and also from the vertebral artery, no more feeders and no more filling. And corresponding to this, you see here a clearly decline in the edema and a clear decline in the corkscrew dilated venous system. So, and now we come to the last case. This was a 67-year-old male, and he reported about back pain in the lower thoracic and upper lumbar region, combined with a progressive, slightly progressive gait disturbance and diffuse paresthesias in both legs. He also had no vegetative disorders, and he reported, but he reported a progression during the last 2 to 3 months. That's the reason why he came to the hospital. And when he was examined, we found a middle grade spinal ataxia and diffuse dysesthesias in the saddle block and both legs, but he had no paraparesis, no paresis in the legs. And got again an MRI scan of the spine, and as you can see here, you see an extensive finding of massive dilated perimedullary venous system from the cervicothoracal region down to the lumbar sacral region. And interestingly, what you also see, or what we also saw, was some infestation of several tumor lesions, like here or here with a small arrow you can see here and here, for example. And interestingly, what we didn't see was a congestive edema in the spinal cord, which you would maybe expect if this would be a spinal dural IV fistula. So you see here another MRI scan with a precise showing of the tumor lesions, like here and here and here. And of course, this patient needed also an extensive spinal angiographic diagnostic, and representative for several segments. I show you here the L1 from the left side and the 9th thoracic level from the right side. You see here high inflow and a high inflow in the tumor lesions, a high arterial inflow in the tumor lesions, an early inflow like here, and during the venous phase, you see the contrast of the dilated venous system here and here. And again, you see here, this is Adamkiewicz, and you see here again several flushes caused by the high arterial inflow in these solid tumors, like here and here, you can see. And then if it goes into the venous phase, you have a decline in the flush, and then it's and the filling of the venous system. So what do you think what this patient had? We didn't know it at the beginning. For a spinal dural IV fistula, we found the dilated perimedullary venous system, but we had, but what didn't spoke for it was the lacking of the congestive edema, and of course, what not spoke for an IV fistula were the tumor lesions. And this one here, and this high early arterial flush that also didn't spoke for IVM, because this picture was not characteristic for an IVM. So maybe it was an hemangioblastoma or whatever. So we decided to operate this patient and to remove one of these solid tumors to get a diagnosis, and then maybe to discuss what we should do. And I can say now we removed this lesion at the level of L5 with the lowest risk for the patient. And now I can tell you that we found a low stroma hemangioblastoma, so we could state the diagnosis of a disseminated infestation of low stroma hemangioblastomas over the whole spinal column. And I want to show you in the video now how we removed this high vascular tumor. And we did it again on the GLOW800. And you see here, we opened the dura, we made an approach via laminotomy of L5. And you see here the fascicles with accompanied vessels. You cannot discriminate between venous and, or sometimes not discriminate between venous and arterial vessels, but this spoke for a venous, a dilated venous vessel. Here you see the dilated arterial vessels, and here you see the partly exposed tumor, red-colored, as a sign for the high arterial inflow. And you see here a bigger venous system, which goes right out of this tumor here. And you see here it's very adherent to this fascicle, and here accompanied vessels. And now we performed here a GLOW procedure, and yes, you can see here, I stop here, you see here a high inflow, one of the main inflow, via this vessel here, and you see the early massive arterial inflow in this tumor. And as you can see here, like in IVF cases, you see here a venous drainage, an early venous drainage out of this tumor. So this technique helped us to identify this branch here as one of the main feeders for the inflow of this tumor. So you see again, if we play with the working distance or the zoom, so you can cause another optimal overlay of the signals and the fluorescence signal. But now we decided to expose this branch here, this main branch, and then we clipped this branch. And again, you see here an early arterial branch, but only a very delayed and a very slowly filling of this tumor, meaning that exclusion of this branch leading to a tremendous regression of inflow into this tumor, and this was a very important information. And you see here the delayed and slowly outflow via this venous drainage from this tumor. So with this information, and we kept the branch excluded from the circulation, and we could more comfortable expose the rest of the lesion, and especially we were able to separate the fascicle from this lesion here in the next steps, and it was much more comfortable to expose the tumor, because if we wouldn't have excluded this branch without this information, the bleeding would have been much more than this. And so we were able to dissect the fascicle from the tumor, and at the end, like in the IVM surgery, we excluded, we interrupted we clipped the venous drainage and dissected the venous vessel from the tumor, and then we could remove this tumor in total. You see here the fascicle and the accompanied vessels, and now the control GLOW800. You see the early filling of the other arterial branches, but no more bleeding here inside. Everything is fine. So this was the last case, and I'm coming slowly to the end of my presentation, and before I come to the conclusions, I want to be aware of some technical aspects. So you should be aware that an optimal congruence between the vessel and the fluorescence intensity is needed to receive the best information. And as you maybe you remember the videos, if we played with the working distance and the zoom, we had an suboptimal overlay between the vessels and angiographic signal intensity. And you should be aware that as high as the zoom is adjusted, as more and overexposure is seen between the vessel and the fluorescence intensity, and as low as the zoom is adjusted, or as low as the working distance is, as less intensity of fluorescence intensity you have. So you should make sure that you have always the optimal working distance to be in between these both extremes, and you should be aware that your working distance is about 375 millimeter, and you have a 4-fold zoom. And maybe this is simple, but make sure that you have an optimal dissolution of the ICG in the medium. That means that you should dissolve 25 milligram of the ICG in 10 milliliter of the medium, what you use, like aqua ad injectabile. And if you do the GLOW procedure, so use the half, means installate 5 milliliter of this solution. So, and if you obey all these technical aspects too, I'm pretty sure that the GLOW800 guarantees the necessary real-time information of the arterial and venous blood flow in the underlying lesion and the adjacent surrounding vessels, what we demanded at the beginning. And this allows you, I think, an optimal overview about the blood flow conditions to select the safest strategy in the treatment, to verify an effective and definite elimination of the lesion, and simultaneously it allows to exclude pathologic perfusion in the adjacent vessels. And of course, this is the great advantage of the GLOW800. You can do all this without a turn away from the microscopic view. You can stay on the microscope, and it guarantees a controlled, strong and tight workflow. So I'm at the end of my presentation, and I hope I could you interested for the GLOW800, and I thank you very much for your attention and your interest in my presentation. Thank you.
Thank you very much, Dr. Renner. We highly appreciate you taking the time out of your busy schedule to be here for this fantastic presentation. Thank you very much. So, dear audience, before we go to the questions, we just want to highlight the Leica technologies that can support brain and spine procedures. Those are the Avio Digital Augmented Reality Microscope, the M530 OHX Surgical Microscope, and of course, GLOW800 Augmented Reality Fluorescence. So I would like to thank you also for submitting your questions, which we will take a look at now. Let's see what the very first question is that came up. Are you using the same ICG solution for GLOW800 as you were using before for FI800?
Yes, it's the same solution.
Okay,
yeah.
That was short and precise. Thank you very much. So can we move to the next question then? Dear Doctor, I perfectly understood the benefits of using GLOW from Leica. Is there any difference in injecting ICG?
No, there is no difference. The technical aspect is the same. You need the same solution of the ICG, and you installate the solution in the same way as before, or is with the other technique. But the great advantage and the great change, or the great advantage of the GLOW800 is that you don't have to switch away to a separate monitor. So you see it through the microscope, and you can stay on your microscopic view, and you see it in the microscopic three-dimensional manner, and in a white light modus, and you see the angiographic picture or the angiography in an optimal depth perception. If you are aware of to keep the right working distance and the zoom, as I told you.
Thank you very much. Then let's take a look at the next question. What is for you the main advantage of GLOW800 ICG compared to FL800 ICG?
Well, the main advantage is that you see the angiographic picture through the microscope. You don't have to interrupt your workflow, and you see it in a perfect manner. You see it three-dimensional, and you got all the information rapidly with the inflow in the vessel system, and you don't have to interrupt your workflow. You can realize what how the perfusion is in the lesion or in the adjacent underlying vessels. You realize rapidly how the flow is. Is it delayed? Is it a normal? And this is all the information you have to control if you would use the F800, because then you have to turn away, and sometimes, and you see it in the two-dimensional manner, and maybe it depends on the lesion, but sometimes you have to switch between both presentations, and again you have to in your imagination you have to overlay these two pictures, and this could be sometimes problematic, and of course you are not able to be aware of all this information in as you can do this as you have this in the GLOW800 technique.
Thank you very much. So next up, our viewers would like to know, what is the biggest advantage for you by having image injection into both eyepieces?
Image injection to both eyepieces. I don't understand what does it mean?
Image injection.
You can see the glow information in both oculars.
Yeah.
Okay.
Yeah.
Okay. Thank you very much for clarifying.
That's the same. Yeah.
Okay, so the next question would be, thank you very much for your cases. Explanations, Dr. Renner. Is GLOW800 helping to teach?
Yeah, I would say it is. It helps very much to teach, because you can be aware of all these sometimes complicated and specific perfusion processes in the underlying lesions, like IVM, like fistulas, like the high volume, high inflow tumor lesions, or aneurysms, whatever you for what you use. But you always see the the normal perfusion, and it helps to understand, I think, the pathologic processes which happen with the underlying disease, and it helps to verify by treating the lesion that you come to normal perfusion processes if you remove the lesion or exclude the lesion from the circulation. So, I mean, you can verify the correct elimination, and you can verify normal perfusion processes after treating the lesion in one workflow. And I think for the understanding and the control of correct processing, it's very, very helpful, yes.
Well, thank you so much.
Yeah.
Thank you very much. Unfortunately, our time is running out. But dear viewers, if you have any further questions, please don't hesitate to reach out to the Leica team. I'm sure they are happy to answer all the questions that you have, and maybe you can also reach Dr. Renner if you have further questions that haven't been answered yet. Our summit will be continuing until Saturday. You can see a snippet of our schedule, so please feel free to register for any upcoming sessions if you want to gain more great learnings. I would like to say thank you very much to you, dear viewers, and of course, thank you, Dr. Renner. I think he's lost connection. So at this point, a huge thank you to all of you. Now he's back. Okay, so I would like to hand over to you for some closing remarks.
Thank you very much. Bye.
Thank you so much. Have a wonderful day, everyone.